Hi, I'm Susan McPeters, Public Affairs Director here at WQPT, and welcome to A Local Look at Mental Health. Now, this program will be followed by the PBS program In Our Own Voices. It's an exploration of mental health issues, and toward the end of this program, we'll have some information concerning an upcoming public forum on mental health. In our local program, we're focusing on women and mental health. An estimated 19 million Americans suffer from depressive disorders, and women are more likely to suffer from depression than men. In women, depression is also often accompanied by other problems, including eating and sleep disorders, panic attacks, and anxiety. Our guests for A Local Look at Mental Health are Dr. Sridhar Yaratha, a staff psychiatrist at Vera French Mental Health Center. Yaratha Fuller is the Director of Consumer Engagement at Transitions. That's an organization which works with mentally ill clients to prepare them for the responsibilities of a job. Ava Dorrance is a therapist with Genesis Health Systems Psychology Associates. Thank you all very much for joining us. And I should also mention, Yaratha, that you have also had experience with bipolar disorder, correct? Mm-hmm. So we'll be talking to you about that, your own experience, and how you have coped with that, learned to deal with it, and how you can probably pass your own experiences on to the folks that you work with now to help them. So thank you all. But Doctor, we want to start with you, and I was wondering if we could just first of all touch upon the most common forms of depression and what the symptoms of those are, and kind of a Cliff Notes version here, and of course in language we can all understand.
Sure. Depression, as you said, is very prevalent in our society, and women actually have a 2-to-1 ratio over men, and they have quite a bit more problems associated with depression. Now, depression can be subdivided into two different kinds, and Yaratha has one of the kinds. One is what we call unipolar depression, or just depression that we normally see. The other one's bipolar depression, which has a different variation in how it presents. More commonly, depression, we look at it as presenting in a constellation of symptoms. It's not just feeling down or feeling blue. It's pretty significant and affect a significant part of your life. One particular way of remembering it, it's back in school and training, we learned something called SIGE CAPS. It's a fancy way of remembering SIGECAPS. It's an acronym. First talks about sleep patterns being very poor, either too much or not enough, loss of interest in activities, either loss in pleasure in, for example, playing basketball or football or something, or knitting or whatever a person likes to do, guilt or hopelessness, energy being terrible, fatigue is quite common, concentration difficulties commonly occur, irritability or mood changes, sometimes that's part of it as well. Definitely some suicidal thought patterns, which are not usually normal. That's not normal for a person to feel like they'd rather be dead than alive. So that there's a certain degree of hopelessness which can occur in depression. And this is what we commonly see. And when a person comes to me or to a regular family doctor, this is commonly what we see in a person who's depressed.
Now, I read once that more women suffer from depression than men, but more men commit suicide as a result of depression from women. So I'm wondering, too, how are we so sure that more women are suffering from it, and it's just that men are less reluctant to go get help? Well, could the numbers be a little skewed?
Possibly, because you look at men are not always willing to go, oh, I'm feeling down, I'm feeling blue. You normally have the old adage, let's pull yourself by the bootstraps and get over this, and it doesn't always work. We do know in research that there is a 2-to-1 ratio of depression women to men, and we know that in this typical depression. In bipolar depression, it's more equal. It's about a 1-to-1. How we know for sure? Well, over the course of time, we figured out that due to either hormonal factors or other factors associated with women, more commonly than men, that we have a higher incidence of depression.
Yeah, I want to talk about some of those factors that make it greater among women. Yaratha, we want to talk about your experience. Now, explain for us, if you can, what your particular bipolar disorder is.
Bipolar disorder is a combination of not only being depressed, but also having manic episodes. I primarily now would tend to be depressed. I had the manic episodes when I was younger. It started when I was 18, around high school.
And this is typical, right, of when it can happen in adolescence?
Yes, because, hormonally there's, you're going through a lot anyway, and I found myself being very moody, and that's typical of adolescence. Yeah. But I found myself being more depressed and just not feeling very balanced at all. And it continued into high school, through high school, and I ended up going to the University of Illinois as a Jane Scholar and wasn't able to stay there because of depression. I was there for about a month. I was just dysfunctional. I couldn't find my way around. I wasn't feeling myself at all, and I had to come home, and that broke my heart.
How were you finally diagnosed then? And how many years later was it?
It was actually later, about 5 years later, that I was diagnosed, and let's see, in my mid-20s.
Mm-hmm.
And then I was put on medication called lithium.
Now, how does it work? I have read that it's episodic,
Mm-hmm.
and so would you have long periods of depression and then short periods of the manic stage where I understand people are very busy and feeling good and get involved in a lot, and how does it balance out?
It's purely individualistic. I tended to be in longer depressions where I felt like I was in a black hole, where I couldn't emote, where I couldn't relate, where I had a totally flat affect. And people wondered what was wrong with me because before that I was gay and happy person. And what happened to Yarmila they knew.
Mm-hmm.
And I had to say to them, because I was still in the public eye in my job, I was catatonic.
Mm.
And I was. But you can't reach beyond yourself when you're feeling like that. You're very isolated feeling.
Mm-hmm. I understand that frequently people go misdiagnosed or they miss bipolar because especially when it happens in adolescence, they get written off as, well, they're just being a teenager. So how do you go about diagnosing this?
Well, I think that's very difficult. You have to look at patterns of behavior, especially with adolescents. You want to talk with family members, even close friends that may have observed behaviors. But I think it's a little easier when the person is older, in their 20s and 30s, to get a better idea because the hormones have such an effect in diagnosing. But when somebody comes in again and again and they describe these symptoms, and especially the mania, you want to find out specifically, how are they acting in manic ways, being very grandiose, thinking they can do anything, spending lots of money, doing things that are not real common to their own behavior in way of being.
Did you ever resist treatment? I also have understood that frequently bipolar individuals don't like the way the drugs make them feel, or they sort of miss the manic periods where they feel that they have so much energy and are even creative.
I didn't resist treatment. My father was a pharmacist. In fact, he sold drugs to state hospitals when they existed more. And when I was manic, you tend to get totally involved in the mania. You're so sped up, and I did have grandiose thoughts, and I had lots of power, and I did spend money, and I do things that weren't within my character, and at those points, you don't realize that you're caught up in this, and it seems real, and it is real. You're living it, but it's your mind speeding up, and the mania and the chemical imbalance in your brain that's causing you to do these things and act this way.
Okay, so go ahead, doctor.
Oh, we're talking about people not being compliant, and we know very clearly that if we put half the people we know on depression and antidepressants, of those 50% or so, only a third of the people stay on it for more than 2 months. And of that, only a third stay on greater than 6 months. And that's the tough thing, because we know that the longer a person stays on an antidepressant or a mood stabilizer, the better it is for them long term. So if we keep a person on medicine at least 6, 8, 12 months, we know we'll have a better chance of preventing recurrence of it. We'd rather not have her ever be depressed again. So to help ensure that, we keep a person on antidepressant or any type of medicine for a longer period. And that, again, is hard. Glad your dad is a pharmacist. It's good. It helped ensure some type of compliance. But that's one of the biggest hurdles in any type of treatment. And doesn't have to be depression. It could be people with heart disease or high blood pressure, diabetes. Ensuring compliance helps prevent problems later on.
So, why do more women than men suffer from depression? Are we getting down to the old bugaboo here of hormones?
Well, there are very distinct periods where we have hormonal changes in women. And we do know there's a higher incidence of mood variability in that time. And we have a new diagnostic classification called premenstrual dysphoric disorder, which previously was known as PMS, but this is more than just PMS. This occurs consecutively, more and more, and about every cycle for 2-3 cycles in a row. And you know that can be prevented. We have evidence and research so that it can be prevented with medicine. There's also time during pregnancy or even after pregnancy. Postpartum depression is extremely, extremely important to treat, because we know if we don't treat that, we have about at least a 1 in 2 chance of having it again. And that's what's scary, because we know we can help treat it. If we don't get on the ball and treat it during those times, we miss it. And again, one of the biggest ones we deal with now is menopause. And there is a big drastic changes in mood, in depression, and anxiety. There's a lot of things occur at that time. And medicine, again, can help. But we do know there's distinct periods that we can help a person with depression.
Mm-hmm. Is there still the attitude, and I'll throw this out to the two of you, that it's just hormones or it's just in their head and somehow they should be able to come to grips with this and get over it themselves? You know, just get a hold of yourself.
Well, being a middle-aged woman, I can really relate personally, but also with my clients, I think that's quite an issue. I think today's world, we still have a lot of expectations of women that are unrealistic, especially as we get into middle age and things aren't happening the way they used to. We have physical symptoms that, you know, are kind of impairing our regular functioning. So, yeah, I think the stigma is still there and does have an impact on us.
Mm-hmm.
Yeah.
I understand, too, that another cause for this, in addition to hormonal changes, can be that women, I guess you would say, take things more to heart than men do, and an event can trigger depression in women more than men. Is that true?
Well, you can look at it in a few different ways. It is sometimes, if you look at more the emotive factors, there is a prevalence higher for women, perhaps. But we look at the overall view, a lot of things can influence or worsen or cause it, depression or bipolar illness. It's not usually one thing. We look at a trio of type of symptoms or ways to influence depression. Let's, for example, first the biological, and we do know there's some genetic link to it, and there's really good twin studies to show that depression is passed on. Mm-hmm. We also know there's some chemical changes where serotonin is affected, and there's some real evidence to show that is affected. Of course, we also know there's a biological reason. Second, there's usually a psychological reason. Some type of trauma occurred in childhood or some real difficult thing for a person to deal with. For example, 2 kids running down the street, one falls and skins his knee, gets up crying, the other one falls and skins his knee, just keeps running again. There's 2 different temperaments. So we do know there's a psychological basis for it. And of course, the social basis of it, for example, changing a job, getting married, divorce, whatever it may be, these are big issues as well. Mm-hmm. So the combination of all 3 can sometimes precipitate such a really severe depressive episode or even worsen a previous existing bipolar illness or whatnot. So I think that's a good way to present an overall picture of how this works.
Talking about this genetically, now,
Mm-hmm.
did you have any other evidence of this in your family at all?
My brother had some problems with depression, my oldest brother. He's 5 years older than I. But other than that, I'm not aware of it.
Mm-hmm. So not concerned about children, or you're not concerned about that you've passed it along to children?
Yes.
Or
I mean,
or,
I think that's a viable question, that it can be. I'm not sure about the linkage and all, or what generation it passed down to, or if it's the next generation, or what sex, or I'm not sure of that information, but I know definitely there's a higher chance of my son having it.
Is depression usually triggered by some event, and perhaps the chemical imbalance was there to begin with, and then the event just kind of takes that person over that edge? Or are some people just, by their chemical makeup, depressed even though something has not really happened to trigger it? Or do we have both?
Generally, I find that we have both, but I will find some event, it can even be as small as losing your pet or that kind of thing that triggers the depression. So there's almost always something that they can put their finger on when it started.
Also, when a woman's involved in an abusive situation, that can exacerbate the symptoms of any mental illness, being under stress. And also, if you have a long-term medical condition, that can cause you to be more depressed. All sorts of situations. And also, if you have a lot of pain, if you have chronic pain for a long time, then that can, there's all sorts of factors that affect how you're feeling.
in medical, that's a very good point you're making, because we do know there's a pretty good linkage with people with diabetes, heart disease, high blood pressure. There's a little bit higher incidence of depression in some of these people due to various factors involved. And of course, chronic pain, you help the depression, you help the pain, and the other way around as well. So there is a very good indicator that we need to check out the medical problems too. And it can't be, it's not always just, just depressed. There are quite a few factors, not just social factors, but against medical factors important to check.
Is there a particular form of depression, because we have the major depression, it runs the gamut, that is you most commonly see?
Bipolar depression is a lot less prevalent, but we do know that major depression in women occurs in about 20% of the population. That's quite a bit. 1 in 5 women may experience a depressive episode in their lifetime. And this is concerning, because it's not just any person with not feeling good. It's a really severe illness, and once treated, it can be better. It is a bit more prevalent, just a major depression versus bipolar depression. And there's all sorts of in-betweens, and it's hard to kind of tell unless you have a long history of a person having depression and bipolar illness. Most women present as depressed, and that's kind of what our presentation sounded like. Men more commonly present manic. So all of a sudden, you already know the guy is bipolar. But again, it took probably 5 years, you said, for an adequate diagnosis for her illness. And because it's kind of muddled, you're not really sure. So I'm glad you got the help you needed.
How do you determine if somebody, let's talk about some of the treatments available. How do you determine if somebody needs just talk therapy, or if you need some combination of drugs and counseling? How do you arrive at that?
We're definitely, being a psychiatrist, I'm always likely to say, let's get someone on a medicine to help. But that's not the only thing. I'd rather put someone on no medicine if possible. We do know that therapy in itself helps a good 55–60% of people who are depressed without any type of medicine. And we know that medicine helps in about 2/3 of cases. But the combination itself helps in over 80% of patients. We know that combination is helpful in every type of case: anxiety, depression, bipolar illness. But the therapy in conjunction is extremely important. And that's not always pushed as well. And we don't have the resources available all the time to refer to a therapist, a clinician, a psychiatrist, and a psychologist. You don't get that opportunity. Sometimes a family doctor has to treat, and that's all they can do because the resources are not there. But if available, I always push the idea of going to see a therapist.
Now, how does that help people? I understand in some cases women might need some sort of assertiveness training.
Absolutely.
Or they might need some counseling because their depression was caused by an abusive situation. So what sort of talk therapy, as it's called, is available?
Well, cognitive behavioral therapy, where somebody changes the critical voices in their head, that's how I look at it, can be very effective. If there are underlying issues, as there often are, it's important to address those issues as well. It can be sexual abuse, physical abuse, as we've talked about, emotional abuse, that kind of thing. So I think a combination of all those things, but it's also important to bring in the family. If
the family has been the cause.
Yes. Well, and also the family can be a great support to the person and help lower the stigma that seems to come along with mental illness. So.
Yeah. When you were diagnosed, what was the reaction of your family? Was it something they felt bad about, or was it relief because they finally figured out why you felt so bad and felt better now that you had some course of action?
For my parents, it was a relief, and I was diagnosed before I got married, and it was one thing I wanted to mention is that taking the medication, I was compliant, but as you were saying, a lot of people aren't able to be. They see it very stigmatizing to take psychiatric medication because of the stigma on the illnesses themselves. If you're diagnosed with bipolar illness or schizophrenia, there's an automatic, unfortunate stigma upon you. And then what happens, you end up self-stigmatizing and you don't even know it. You feel lesser than because other people see you as lesser than. And you can become part of the mental health system and you feel trapped and you feel like your life is over. But what I'm promoting where I work and in my life is recovery. That there is a chance, a great chance. It's not even, the word chance isn't even on it. You can recover, that you can get your life back. I can be the person that I was before I was depressed. And that's with the help of medication and with talking to a psychiatrist and talking with therapists and having peer support also. Peer support is by talking to other people who have the same illnesses. And at Transitions we have peer support groups that really have turned out to be tremendously beneficial because we're in the same boat together. And we support each other and we validate each other. And there's a lot of growth, incredible growth out of a situation like that.
Now, how did you handle that? Because unlike somebody who suffers from depression because perhaps a spouse died or something and they're going through a depression because of that, and hopefully they'll eventually get over it, bipolar disorder is not something that's ever going to go away. So how did you approach that when you met people or you got involved in a relationship? You know, at some point I've got to let them know this, but also let them know I'm okay.
I basically I am very upfront with it. When I applied at Transitions, I let them know that I had bipolar illness, but I also let them see who I am now and what I've overcome and what everyone can overcome with the help of God and also with the help of professionals and their family and a peer support group.
Now, how are you treated now? Are you on medication, or do you also still have some sort of therapy? What is your current treatment?
My current treatment is Depakote, which is an anticonvulsant that is used for manic depression. It helps stabilize the brain chemistry. And I'm also on Prozac. And it also helps with PMS. And Ativan, a small dose of Ativan at night to help me sleep.
What about the drugs that are available? I've heard that they become vastly improved in terms of side effects. They don't make people dopey anymore. They work faster and they work better. So what's happening with the drugs these days?
We do know that the side effect profile is so much better. We're tolerating medications better. Prozac was one of the first ones that really came out that revolutionized treating of depression. Unfortunately, it got a little bad rap initially, but still we know it's one of the best medicines to work. The newer medicines, we've heard of Paxil, Zoloft, and they've been touted on TV. You see them all the time, little happy ball running around, hey, we feel good. But then also you hear on the radio the Effexor. You hear people talking about Effexor here. But there's some that are not out there, like Lexapro or Celexa or Remeron or Wellbutrin, who are just as good. Just finding a medicine that works for you is important because the side effects are so much better tolerated, and you can stay on them for a long time. You talked a little bit about the inevitability of being on medicine for a long time. Depression, if treated the first time or the second time and treated adequately, people do well. And after a year, maybe 2 years on the medicine, they can get off of it eventually. But after the third, fourth episodes, it's very concerning because at that point, the depression won't remit unless you stay on the medicine forever. And again, it becomes a very chronic illness. Treatable, but chronic. And in the same vein, you know, you have to be on medicine for a long period of time. If it is lifetime, so be it. I have a young lady, a 26, 27-year-old female who's had serious episodes of depression after all three of her pregnancies. And so severe that she couldn't do anything, get out of the house, eat, sleep. So now she's relegated to be on medicine the rest of her life. And she's okay with that. She feels good on the medicine. There's no problem, no side effects that were intolerable or any effect. And she's doing so much better. But it took a while for her to realize I need to be on this medicine for a long period.
How about therapy? Is it forever? Or, you know, we hear about Woody Allen, like seeing a psychiatrist for 30 years, and you think, or can it also be just kind of a short-term thing to get a person over
I think
a hump?
Woody Allen is definitely an exception to the rule, and he has the money. So, I think it can be shorter term, 6 months to a year, possibly even shorter than that. Sometimes people need what I call boosts, you know, periodically if they suffer from depression. Something may come up that they want to deal with. That's pretty natural too. Yeah.
Is there anything that people can do to prevent it, that women can do to prevent it, if they see that there's been a family history of the women in their family not doing well with menopause or something?
You definitely talk to your doctor. I mean, it doesn't hurt to talk to your family physician. Hey, this is what's going on. My mom has really bad depression. My grandmother had real bad depression. You know, I seem to have some mood changes. What do you think? At least keeping track of it is important. Understanding your family history is, again, very important. Just like as with any other illness, heart disease history. You have to know that because you might have a higher risk of it as well. Just the same for depression. It's very important to know there's depression history in the past, though. In the old days, people just felt down. You know, grandma just didn't feel like it a lot. You should definitely look at that and kind of go back and ask questions. There is depression in the family, then maybe we need to be more on guard. And I think that's also something very important for any type of illness.
We only have a couple minutes left, but one thing I want to ask you about, because I understand it's sort of undergoing a resurgence here, is electric shock therapy.
Yes, ma'am.
Which, and I remember Thomas Eagleton, who was running for office many years ago, admitted that he had this for depression, and he had to drop out of the race. People thought, this man can't be in charge of running the country. So how exactly does it work?
Well, it's actually the most effective treatment for depression we have. Upwards of 90 to 95% effectiveness for treatment. And you can help a person in a matter of 2 to 3 weeks versus 3, 4, 6, 8 months. It works by changing the brain chemistry. It changes how the chemicals in the brain work. You still have to be on an antidepressant, but it does work, and it works fairly quickly. We do know that getting a person on the treatment of ECT in a very severe situation is extremely helpful. A lot of patients come in. A lady who had a husband die, and she was not eating, not sleeping, not taking care of herself, and eventually had kidney failure because she wouldn't have any fluids at all. In such a severe case, we took care of her, fixed her with ECT, and she's much better. She still needed antidepressants, but she does that, and she takes it, and she's doing much better long term. So we can do that if we get it early on as well. It's not the last line anymore. We know a lot more research has been done to show that it can be helped first line too. But of course, you consult with a psychiatrist or family doctor to make sure.
I am evidence that that works. In the 90s, I had 16 electroshock treatments. And slowly, after each session, my personality came back. Prior to that, I was totally flat affect and I didn't have myself. But after each session, at first I wouldn't have very much memory, but then I got my memory back, and I also was getting my personality back, and it was really a miracle.
Well, that's great. We're going to end on that up note then, and thank you all very much for joining us, and we'll see you at our panel discussion too. And we do want to remind folks that we do have an upcoming public forum. We've got some information for you on where that's going to be held. And RSVP is not necessary, but it is appreciated, I think largely so they know how many snacks they can provide. But if you are concerned about your own mental health or concerned about the mental health of a friend or family member, you are welcome to come to that. And if you missed the phone number there, just give us a call. And also, this program is going to be repeated, as well as the PBS program, which is going to be following this one. So if you know someone that you think should watch this show, you have time to tell them as well. Again, a thanks to all of our guests, and thanks to you for watching. Bye-bye.